So Glenn, as we get ready here, I will start talking a little bit about our next presentation. I know we're running a little ahead of schedule, so for those of you who are waiting for 12:45 Pacific, we're sorry, but we're gonna get going. So we're gonna talk about sacroiliac joint fusion. There's been a long history with SI joint fusion. Surgeons have been doing it for decades, going back to at least the 70s, if maybe longer. And in the last 10 to 20 years, there have been some new approaches coming in from a lateral approach that involves screws and rods, namely the SI bone iFuse system, the Zygous symmetry system. And in the last 5 to 8 years, we've had development of a posterior sacroiliac joint fusion technique. And the advantage to this technique is that you avoid the superior gluteal artery, you avoid some major vascular complications, and migration seems not to be an issue. What we notice from this technique as well is that we're really not leaving in any hardware, we're not screwing. What we're doing is replacing cadaveric allograft and demineralized bone matrix. And so we're using some of the techniques and applications used in spine surgery for the SI joint. And so what happens is when we place this allograft, which Lewis will hand to me, and I'll show you in the camera here, if you want to zoom in on that. Perfect. In this allograft, and these little holes, we're able to place that DBM, or demineralized bone matrix, and we place this in the joint, and there are two things that occur with this. Number one, we create distraction of the joint, which is advantageous, particularly with a patient with sacroiliac joint arthritis or sacroiliitis. And then number two, what's going to happen over time is that because we decorticate the bone of the sacrum and ilium, it's going to promote growth across that allograft. And one of the most important things to tell your patients is that we don't want them to sit for more than an hour. We really don't want them sitting down, because what that does is it changes the angulation of the ilium on the sacrum. So we encourage them to walk, stand, lie down all they want, but not to sit down. And most of them will say, that's no problem, doc, because when I sit down, that's really when I have pain, right, with sacroiliac joint dysfunction. So this is a different way of approaching the SI joint. It's very simple if you know how to do an SI joint injection, which I'm sure all of you know at this point. And so basically what we're doing is you're doing your injection like you would for the SI joint, and we'll show you some little nuances as far as where we place things. And then we're using a system of dilators to open up that space, open up that joint, have that cannula, and then place the allograft and DBM, and then take everything out. So this is very similar to what we did with Vertiflex just earlier this morning. Now we're applying those same kind of principles to the sacroiliac joint. One of the key things with PainTech, the company we're presenting today, is that they have invested in gathering level 1 evidence. So we are underway in a study to really examine the benefit of this particular system. The SI bone iFuse system does have level 1 evidence for that lateral approach. We surmise our outcomes will be similar, but with an enhanced degree of safety and a reduced operating time. So if you're an interventional pain physician, especially if you're getting involved in minimally invasive spine approaches, this is certainly something to think about. There are over 20 SI fusion companies on the market. And so I encourage you to do your own diligence, do your own work to figure out who would be the best for you to work with. So again, I'm going to demonstrate for you the PainTech system. And this is their latest and greatest generation of instruments. If we can get a camera view of these instruments, that would be ideal. Should we use this camera, guys, to come down, or what do you think is best? This one? Okay. So I'll show you these instruments real quickly, since we have a little bit of time. So number one, this is our tissue dilator, or colloquially the joint finder, and our tangs go over it. It is notched, so everything comes over like this. So once I get my K-wire or Steinman pin into the joint, and basically our approach here is to be parallel to the sacral ala or the L5 inferior end plates, and lateral to the S1 neuroforamen. So we'll get the Steinman pin or K-wire in. Then you can see the shape of the scallop here. We want this side, the longer scallop to face the ilium and the shorter scallop to face the sacrum. And so that is the orientation we'll take. We'll place that over the K-wire. This will come out and we'll have what's remaining, this cannula. And then what we have is the box cutter, which decorticates the bone on both sides. Again, it's slotted, so there's a specific orientation. And we take that out with a slap hammer if necessary, and then we have the allograft, and then that goes in, again, slotted to an orientation, so everything looks good. And then basically, you just pull this out, and it after unscrewing it, the tangs come off the allograft, and everything is left in place, and then you suture it closed. So this can be a very quick procedure for us to perform. So let's get started. Justin, if we can come back to that angle of obliquity we had before. So as you all know, if you think about the pelvis, I don't think we have a pelvis model, but if you think about your SI joint itself, there is an angle of obliquity to how you enter. Oh, this is perfect. Lewis has this picture here. We've got this model. I'll bring this in here. So Tyler, do we have it? Perfect. So this is looking basically at an axial view of the SI joint or the pelvis. So here are the SI joints here on either side. As you can see, when you want to do your interventions here, we want to be parallel to that joint. So that's why often your needle insertion point is almost right at midline, or somewhat ipsilateral, but generally you're coming in at this medial to lateral approach. And so that's exactly what you're gonna see here. And so we'll start with that. And that's why Justin has this angle of obliquity if we're gonna do the left SI joint. So we'll take a shot there, Justin, and line up the joint. And I will take a marking pen if you don't mind, Lewis. And Tyler, can I get a knife by any chance, a scalpel? Perfect. Oh, you got one here? Okay, great. All right, so here we go. I'll just use the K-wire itself as my radiopaque object. You like that, Lewis? Yep. Okay. He's very happy. I'll probably come a little bit more cephalad. We already have a previous incision here. Perfect. Okay. So that's going to be a nice placement for our K-wire. So what I'll do is I'll actually incise. The length of your incision, as Lewis is holding here, is really the distance between the tangs. So you can actually use this instrument to help you understand what the length of the incision should be. There's already an incision from I think our vertiflex before, so it looks like I'm extending the incision, but really I would just have basically a 1.5 to 2 centimeter incision here. Usually I would use a little bit of electrocautery, but not absolutely necessary. There's no major vascular structure in the way here. And I just use my finger to palpate down onto that joint itself. I'm pretty tactile in general, so I like to feel down. So then I'll take that K-wire. No worries. And we'll just see how this looks here. So I just want to follow the angulation of the C-arm. Yep, we'll get a little bit more lateral here. So again, a lot of this is just a feel. And then I'll get into the joint and I'll stand it up a little bit straighter. Perfect. Stand it up a little bit straighter. And I'll start to probably mallet here. You liking that? I like it. Perfect. Yeah, feeling good. Let's check a lateral. We'll take a shot there. Yep, we'll check a lateral. So key things there, really encourage you to think about doing your SI joint injections like you would do these procedures. I'll give you a little inferior, and I'll use the mallet here. So just like Glenn was showing you this morning with your spinal cord stimulator trial, one of the things you guys should think about in your fellowship is now doing all of your interlaminar epidural steroid injections as if you're going to do a spinal cord stim trial. Everyone knows how to do interlaminars, they're very straightforward, but now you can start to apply that technique and get sort of a mental routine on how your muscles act to get that trajectory. And similarly here, for the basic procedure, like an SI joint injection, you can start to think about how you would do a minimally invasive SI fusion procedure. So a couple things here with that Steinman. What you see, what I'm doing here is I'm trying to angle a little bit more inferior, so I'm trying to be parallel to the sacral ala and the L5 end plate. So I'm getting a little bit more parallel. Yep, I'm gonna pull back just a little bit and get a little bit more inferior. Let's see if that will. I want to pull back a little bit further because it has so much purchase in that joint. You liking that?
Yeah.
Okay. So I'll really try to drive it caudal here. It's too much purchase. You want me to keep that parallel? Or do you want me to get a little bit more caudal?
A little bit more.
Sure. So I'll pull back and I'll re-engage in the joint here. And I'm maintaining that same angle of obliquity, but now with a little bit more caudal tilt.
Try to do, yeah, just think we'll drop in with tactile.
You want to come back around and ensure? Yeah, let's do that. So we'll make sure we're absolutely perfect. When you have significant purchase like that, the K-wire wants to follow the track you initially take. So we'll take a look again under our oblique and come in a little bit more inferior. All right, Justin. Yep. And shot there. Cool. Looks great. And I think now that we know what it looks like under lateral, perfect. And we'll go back to our lateral here, Justin. I think just looking at the K-wire outside of the body, you can see its angulation is looking much better. Everyone's sacrum is different. Everyone's sacroiliac joint is different. So, you know, you're gonna see these different angulations, especially depending on the position of the patient on the bed. Liking it?
Yeah.
I'm liking it.
Going down.
Yeah. Perfect. So it's just following that S1 neuroforamen, basically. I am still putting a little pressure towards the head so it heads caudally. Looks good. Okay. Perfect. All right, and I think we are good there. So now we can use our tissue dilator. Perfect. And as you can see from our instrumentation, it's all dilated, or slotted, I should say, so that everything lines up perfectly. The orientation is so that the large scallop is towards the ilium. And you can see it just goes right over that wire like so. And then I can start to mallet here. Justin, do you mind coming back around to that oblique here? So one of the things I just want to make sure of is that my tangs are right lined up with the joint.
Yeah, let's mallet down all the way to the joint first.
Okay. Maybe, Justin, if you don't mind, just going back to lateral and mallet a little bit further and make sure that we're...
Mallet it down to the joint, just right outside.
Need a bigger hammer. Hold on 1 second, shot there. Yep. Little shot there. And now I'm gonna try to become, a little more parallel to the sacrum here. Let me get it to the joint. Shot there.
Okay, so let's do that.
Perfect. Now let's check, under that oblique angle. Just make sure the tangs are lined up with the joint. So I can do a little rotation. And we'll just check, can you head cranial with the II here, Justin? Just want to make sure the top is lined up. Yeah. So can you be more cranial than the angulation of the instrumentation? So like Super Ferguson. Yep. Yep, keep going. There, yep, that's good. Oh, the table's, the pedestal's hitting you. Okay. Well, maybe what I'll do is we'll move our patient. Yeah, we can move the patient as well. Okay. I do these procedures on a Jackson table flat. It allows for a lot of space because of these significant cranial and caudal tilts on the fluoro. The same is true for when I do vertiflex. It just allows you a lot of space. Yeah, looks good. Top tine is right in the joint. The bottom tine we saw. Perfect. All right, so we're good. We'll go back to a lat. All right. Justin's getting his workout here with the C-arm. All right, so I'm just going to keep on malleting here. And once Justin gets that lateral, we'll take a shot there. And I can do some manipulation here. I can still, put a little tension on this to head more caudal. Shot there. I'll keep it going. And I can feel the purchase improving here. Shot there. A little bit further. And what Lewis is looking at here is to make sure that the dilator itself, you can see the radial lucent part. If we can take a picture of us on the screen. Do you guys have a view of us pointing to the screen here? I don't know if that camera can look at us. But basically, what we're trying to ensure is that radial lucent part of the dilator is right along the posterior wall of the sacrum. Yep, exactly. So good there?
Yep.
Perfect. We'll come around to that oblique. Perfect. Everything comes out. And if we just go right down the barrel, Justin.
Down that barrel a little bit. And then push in. And then see over. Bring the C over. Yeah, right there. Just take a shot.
Yeah, let's take a shot there. Let's see what it looks like. Perfect. Just like we did with the vertiflex. If you guys recall, we had that cannula view where we just went straight down it to look, and we're just trying to line everything up again. This is not easy on Justin because he's seeing all these new procedures for the first time, and so we're throwing all these different things at him. So you can see here, just even in this specific shot, that those tines are really right in the joints, and that's exactly what we want to see. And that's going to be our working cannula as soon as he is able to. Yep, that looks good. And then more oblique to.
So come back this way with the C.
And then oblique, the II towards you, Justin, about 5-10 degrees. Yeah, take a shot there. I think you're going to have it. A little bit further. A little bit further, Justin. More oblique, more oblique. Yep. Okay, there we go. So that's what we're looking for down the barrel. You can see both sides of the joint, the sacrum and the ilium. This is where everything is going to sit. One of the things you can see in your live patients is that joint has distracted to some degree. You can see that here to some degree, although this is a pretty wide joint. This is not a typical joint you're going to see in your patients because most often that joint space is compressed, it's collapsed, there's sclerosis. But in this particular specimen, it actually looks pretty good. All right, so we'll go back to a lateral. And this is the box cutter. This is going to decorticate both the sacrum and the ilium. And Justin's going to come back around to a lat. So again, this is oriented, it's slotted. There's a dark line here on the top of that cannula that allows me to see. And I'm just gonna take it down manually with pressure, and then I can mallet a little bit further. Shot there. So this is what it looks like before. Oftentimes, for your patients, there can be a little bit of blood here, so I recommend just having 4x4s or laps here, just in case with every mallet that's coming back on you. Shot there. Perfect. And you can see this is basically creating the template for my allograft with this box cutter. Shot there. A little bit further. I think we're getting there. Shot there.
Might as well seat it. We're almost.
Yeah, I think so. We're gonna go ahead and seat this guy. I think that looks good. Shot there. Looks great. All right. So now I think this is the coolest part of this new generation is I can unscrew this handle, and now I'll keep my hand on the cannula here, making sure this doesn't move, and then I'll basically slap hammer this out. And there we go. That comes out. Perfect. And then again, now here's that allograft, which would typically be filled with DBM, and it's slotted again, making sure everything looks good. Perfect, and a shot there, just to show where we're at. I'm not quite out, obviously. And we'll just take a shot, we know we're gonna have to seat it, but it's just nice for you to see what it looks like radiographically as this inserts. Shot there. And we're almost there. All right. Lewis, you like that, or should I seat it all the way?
Yes.
Like Doug Beal says, more is better. Perfect. All right, well, looks great. And then the cool thing about this system is you just pull it out and we're all set.
Right out, yes. Pull the handle out first.
And that's it. Love it. All right, you can take a shot there, Justin, see what that allograft looks like there. You can faintly see it, but it's nicely parallel to the ALA and the L5 end plate. So that's it. We'll go back around to that original view of the joint. We'll take a look at what the allograft looks like sitting in the joint. Again, with this approach, we are right at S1. Yeah, it looks good. And we are parallel to the sacral ala and L5. All right. Well, that concludes that demonstration. Glenn, are there any questions coming in from the audience regarding the PainTech Link SI Fusion system?
Yeah, there were some questions. They were asking, do you do this under general anesthesia, Ramo?
That's a great question. I have been doing it more under general anesthesia lately. I try to do as many of my cases as possible under MAC, but I did have a patient who was moving a bit, and ever since then, the anesthesiologist and I had agreed that we should do more of these under general anesthesia. There have been patients where we feel like they're really stoic, they can handle things well, and we've done it under MAC. So it's really dealer's choice, whatever you're most comfortable with. I think the most stimulating part is when the dilator is put in. That distraction of the joint sometimes is stimulating for the patient, but then after that, really, everything is pretty straightforward. Some of the things you can do to reduce the stimulation here, you can anesthetize the joint like you would for an SI joint injection. That might be helpful for stimulation here.
Excellent. That was the main question that people had. Do you typically do an SI joint injection? I know you went probably superior part of the joint. Typically, the SI joint injection is done in the inferior part of the joint. Any comments on that, Ramo?
Sorry, Glenn, I couldn't understand the question very well.
Typically, the SI joint injection is done on the inferior portion of the joint.
Right. Okay, so that is a very good question, right? So we're accustomed to doing our intra-articular SI joint injections in the inferior third because that is where the largest volume of the joint is. And in fact, I was just talking with Lewis about all the different approaches we've kind of gone over in the last couple of years with all the different SI fusion companies. So there are pros and cons to all of this. One of the pros for the inferior approach is that there's a large volume of joint space there. The con is that you can get relatively close to the sciatic notch if you don't watch what you're doing. I think that as long as you're ensuring that you're well within the joint, we haven't proven that one location is superior to the other. But I'll tell you, in the last 2 years, I have placed allograft pretty much in every single location in that joint. And I'm not sure one is better than the other. I just think if you get allograft in the joint, it's well seated, and it fuses appropriately, you're going to get the outcome that you're looking for.
Okay.
I'll just mention, Paintech is one of the primarily 3 companies in the posterior SI fusion space. One of the other companies, Cornerlock, uses 2 allografts at orthogonal angles. Question is whether there's benefit there to doing 2 versus 1. I would argue that as long as you have allograft in and that promotes a good fusion, then that's all you need. But if the evidence proves me wrong on that, then by all means, I'll stand up and start doing that.
Neil's got a question here.
Great presentation. Neil Shawnard asking, fusion often involves a biology issue, and sometimes the patient's biology and sometimes the environment of fusion alter the success rate. Are there patient characteristics that you recognize raise the difficulty in obtaining and securing the fusion? And if so, what do you do in those circumstances?
Neil, that's a great question. And you're so, well knowledgeable about these issues because of you doing fusion in the spine all the time. We certainly know that, smokers, those with uncontrolled diabetes, or even those with just poor protoplasm. You meet the 98-year-old woman who, you take a fluoro shot and it's basically like there was nothing there because their bones are so frail. Those are going to be challenging situations. You're right. They're probably not going to fuse as well as we'd like. And that perhaps a more hardware-oriented approach might be better. But it's hard for me to know that. There's so little we know about posterior SI fusion approaches and the use of allograft and DBM for this situation that you just wonder if the fusion is absolutely necessary, because there is a possibility that simply distracting the joint is a big driver of what reduces pain, and that maintaining mobility of that joint might be okay. I mean, we certainly know that there are 3 to 4 degrees range of motion with that joint in a normal joint. And we're not, I don't claim to think that fusion is the answer necessarily, and maybe it is, but I'm not sure. I mean, maybe just distraction does it all. And so I think this is just a wonderful question, Neil, and I think we'll have to figure this out as we move forward. And I certainly know the more patients that we really look at and study and understand what their characteristics are will help us have better outcomes.
Okay. Well, a couple more questions here. Do you consider this after rhizotomy of the SI joint?
That's a great question. So if you think about your treatment algorithm for sacroiliitis specifically, because the diagnosis, as far as Medicare, really is sacroiliitis, so you want to see radiographic finding of inflammation around the joint. Historically has been intra-articular steroid injection, followed by lateral branch diagnostic block, followed by lateral branch neurolysis with standard synergy, cooled RF, and then potentially fusion. I think in our world in interventional pain, historically there's been this idea to go from least invasive to most invasive. But if it turns out the more invasive procedure is the one that has the best efficacy and a good safety profile, and really little to no harm, and it's potentially reversible or doesn't prevent any other modalities, then you should start considering those things earlier. So I would consider the Superion one of those devices where it might seem more invasive than epidural steroid injections or other modalities, but since it has such great evidence to support it, you think about it much earlier in the algorithm. I'm not doing injections necessarily when I first meet a patient with lumbar spinal stenosis. I might go right to Superion. And similarly here, I might consider fusion earlier on, but the caveat being right now, I just don't have that level 1 evidence and the comparators to really go to it right away. But often, I have patients who do fail radiofrequency ablation, and if you do look at the studies, there's about a 30 to 40% failure rate for those neurolyses of the SI joint because it's a complex system, and we know that the anterior neural network for the SI joint cannot be touched by RFA. You're only dealing with the dorsal or posterior aspect. So fusion might have a role there. So yeah, it's a really interesting time right now to figure out where these things fit in the algorithm.
Okay, excellent. I'll just do one more here. The question was, this small size graft, is it enough to hold the body weight in this big joint?
I think the question was, is that small grafts capable of holding open the joint? And the answer is yeah. So these companies have really spent a lot of time and effort trying to make sure that it's the appropriate size, the appropriate shape, that the contours are exactly what are probably best for the SI joint. I think over distraction is a problem because especially if you only have unilateral symptoms, you're going to have pelvic asymmetry. So I think this size is actually quite appropriate, even though you will see some distraction as you do it. But you know what, guys? I don't have all the answers, and I don't think the companies have all the answers right now either. There might be a different volume, shape, length that might portend a better outcome, and I think time will tell.
Well, excellent. Excellent presentation. Thank you very much.
Thank you.